So let me move right along here and introduce Nichole Tanner, who was Associate Professor of Medicine at the Medical University of South Carolina. She's also co-director of their lung cancer screening program and has done really tremendous work in both screening and lung nodule management. And I want to have her give us an overview of pulmonary nodule management as it stands currently. Nichole.
Thank you, Anil. Good morning. Thank you for joining us. Okay, so I'm going to talk to you guys a little bit about pulmonary nodules, which is an increasing problem that we see in our practices. And so this article, which was published in the Blue Journal in 2015, I think is a really important one in that it highlights the impact and the issues with pulmonary nodules. And so they're a common incidental finding. Every time you show up to the emergency room with shortness of breath, you get the obligatory triple rule out. And so there are a lot of incidentally detected pulmonary nodules. And so this analysis was to look at recent trends because up until now, we had been quoting 150,000 new pulmonary nodules a year, and this was based on chest X-ray data out of Mayo. And so the folks at Kaiser Permanente did a very elegant study looking at their integrated health system and looked at the different scanners and all of the results, and through some mathematical acrobats came up with these numbers. And so what they estimate was that the number of chest CT scans done were about 4.8, and the estimate of lung nodules annually across the United States is 1.57 million. So who are going to manage those nodules? And that's kind of where the question is and where the discussion is today. And so this updated estimate really highlights the magnitude of the problem, which can be a diagnostic dilemma for many clinicians, maybe not you in this room, but oftentimes we don't know what to do with these nodules. And this is only expected to get worse as lung cancer screening is implemented across the United States. This number is before lung cancer screening, so you can expect that that number of 1.57 million is likely to increase even further. So this is a real problem. So it's a problem, but how do we manage? And that's what the question is. We have guidelines. There are guidelines. Here we are at the ACCP meeting. There are guidelines for pulmonary nodule management. The third edition was just published in 2013. The British Thoracic Society also has a very elegant group of guidelines that was published in Thorax in 2015. I would encourage all of you to take a look at these guidelines. I think they're extremely helpful and can really guide you in how you manage nodules. But the basic premise of all of this is to assess the likelihood of malignancy. Both sets of guidelines say you need to ask yourself, what does your clinical intuition say? What's the probability of this being a lung cancer? Because that's what we're all worried about, right? You've got a small dot. Does that small dot equal a cancer? And obviously patients are very distressed when they hear they have a nodule. And so the guidelines all recommend either using your clinical judgment, your gestalt, or a risk calculator. And there's a number of published risk calculators that are available. But basically, you want to look at the probability of cancer. With a low end here, you consider serial CT scan, and in the BTS guidelines and the ACCP guidelines, this differs a little bit. In the ACCP guidelines, it's about 5%. The BTS guidelines say 10%. High risk, you want to consider going to surgical resection. ACCP guidelines, 65% and greater. You consider if the person's eligible for surgery and you're that concerned to consider surgical resection. The BTS guidelines cuts it at 70. And then you have this big, vast group of intermediate risk of anywhere from greater than 5 to 65% or 10 to 70, depending on what you look at. And so that's kind of the catch-all. Most are going to fall in there. And that's where the evidence isn't good. So you have to have a conversation with your patient, have a shared decision-making visit, see what's important to them, talk to them about the nodule, show them the nodule, let them understand what it means, and make a plan together. But in this intermediate risk category, the recommendation is to do a PET CT scan or follow that with a biopsy. And then, as we said, in the low risk, this is less than 5%. You want to do surveillance, CT surveillance. You want to provide reassurance to your patient. This is a very small nodule. I'm not dismissing it. We're going to continue to follow it. It's all in the conversation. So assessing pretest probability for malignancy can be done, as I said, with clinical intuition or with validated risk models. And there's a number of these validated risk models, but they're very dependent on the prevalence of malignancy in the population. So in the VA model, there is about a 40% cancer rate. In the Mayo model, which you can find on chestxray.com, I believe, there's a 24% cancer rate. And in the Brock model, which is what's used in the British Thoracic Society guidelines, which was developed out of a screening trial, it's about 3 to 5%. And so this is a big schematic to kind of demonstrate what you want to do And this is available from the CHEST guidelines. And so I just want to highlight that I'm talking about the 8 to 30 millimeter nodule. Anything that's less than 8 or much smaller, CT surveillance is typically what we would do. And so you really want to look at the person's ability to undergo surgery. And if they're at a low to moderate risk, you would assess the probability of cancer. And here's where you could insert your calculator and you come up with very low, low to moderate, or high. And the steps are as follows, okay? Similarly, if you look at the BTS guidelines, again, it's to calculate the pretest probability of malignancy. Interestingly, they actually recommend using that Brock model that I pointed out. And based on what the calculation is from the Brock model, you go ahead and follow less than 10% risk CT surveillance, greater than 10% risk. They recommend going straight to PET scan and incorporating the PET scan with another model that is called the Herder model, which includes SUV uptake. So it's a different approach. I think it's thoughtful, and there you have that. So you always want to assess risk, which is the most important piece here. So the next question that we have is really, we have these guidelines. How well are we doing with these guidelines? How well do people follow the guidelines? And what's done in the community? And so our group published this in CHEST last year, looking at the management of pulmonary nodules by community physicians. And so this was a broad study across the United States with 18 outpatient community pulmonologist practices, looking at 377 patients. And basically the point of this study was to document the diagnostic management of these patients and compare the relationship between pretest probability as calculated by a nodule prediction calculator to what was actually done. This is limited in that it was a retrospective analysis, and we might not necessarily know what the patients wanted or what the physician conversation was. But what you see here is that in the low intermediate risk category, the numbers of benign versus malignant as you go up. And then I would draw your attention to the most invasive procedure utilized. And what you see here is that it didn't matter. Didn't matter if you were in that low risk, less than 5% category, or intermediate risk category, or high risk category. Surgery was being used the same across all categories of risk, which begs the question, what happened? I mean, could there have been a nervous patient that says, I don't care, doc, it's less than 5%, I still want it taken out? But you see that there's really no relationship, as you would have expected with the guidelines. As the risk goes up, you would expect the surgery to go up, and as the risk goes down, that surveillance would go down, but there is no statistical difference. So in conclusion, I think pulmonary nodules are a common problem. They're likely to become an even more common problem as we introduce lung cancer screening throughout the United States. There are guidelines that exist to aid in nodule management. I would encourage you all to look at them. They're available on the ACCP website. And all of your nodule management should really be driven by your pretest probability for malignancy. So you have to ask yourself, is this cancer or is it not? And there are models that can help you do this. And with that, I will end.